So, welcome everyone to our first live presentation on the mechanical assessment tool or MAT evaluation. Today we're putting that fearful MAT evaluation into easy mode. So I like to call it MOVE, M, and A, test, MAT, rather than those big long words. I mean, it's not the official name, but I like to think of it in this way to get down to the crux of what we're actually aiming for, a MAT evaluation, so we don't get caught up in technicalities or terminology. So today we are breaking down the basics of a physical or postural assessment, such as a MAT. And hopefully it will empower OTs and physios alike to confidently use objective posture and body measurement assessments in everyday practice. So no stress. We're just going to look at some straightforward solutions. You may ask why it's worth tuning in on this early morning. Well, by the end of today, I want you to be able to answer three basic questions. What should we focus on to assess a person's posture? Why do we do this assessment of their posture? And how do we do it? For those that haven't met me, my name's Rebecca and I'm the Head of Clinical Development for Neuro and Assistive Technology OT at Optimum. I've got experience across hospital and community settings, supporting people with all different diagnoses, aged from children to older adults, but predominantly I've worked with adults. I have particular passions for neurological conditions, so MND, MS, that are those particularly progressive deteriorating conditions, as well as assistive technology. Do keep in mind that this presentation is just a taster. I'll actually be doing a hands-on face-to-face MAT eval workshop on the 13th of September at Optimum Health Solutions North Rocks. The marketing should come out for this shortly, so just watch this space. So I've made it pretty clear today that I'm not focusing on too much of the science or overwhelming you with technicalities. I'll be keeping it simple and straightforward and maybe a little humorous, because I want you all to not think that this is anything insurmountable or complex, because how likely are you then to take that into your learning and apply it? I think a big part of this learning is having the opportunity to apply it face to face. So I'd encourage you, if possible, to attend the in-person workshop. And you'll also have an opportunity to meet Louise, our Head of Clinical Development in Neuro, as physio, and a very exciting special guest, which you'll hear about through marketing soon. But if attending the workshop isn't possible, after today, either reach out to myself or try it out with a colleague or a friend or even a family member, so you can really understand what we've learnt and just practice, because it's definitely something that you develop confidence in over time. So let's start off with that first question about the why. Most basically, when we talk about posture, we're referring to the alignment and positioning of a person's body in relation to gravity, so whether they're sitting, standing, or lying down. A person's posture or body position can be affected by their disability, so due to factors like muscle weakness, joint limitations, neurological impairments, or pain, which can lead to things like discomfort, reduced function, or secondary complications. So you might think, why is this important? So as OTs and physios, we should be assessing posture both independently and collaboratively as a multidisciplinary team, so we can ensure that this person is in the best position to engage in daytime tasks and overnight sleeping or rest. And we may do this through using the findings of their postural needs to implement equipment, such as seating or mobility aids, or sleeping systems. And this can then support that person's task participation by having a posture that promotes optimal comfort, function, and general long-term health outcomes. So let's get into it. I want you to think of doing a postural or a MAT evaluation as being a chef creating a sandwich. That's right, I did say sandwich. So you're going to be checking which ingredients or body parts are soft, crunchy, or need a little extra spread to hold everything together. So the aim is the sandwich of stability. So you know the one where you have every ingredient sitting on top of each other. There isn't any tomato slipping out the side, the ham isn't on one half of the sandwich only, and you haven't got lettuce falling out everywhere, and you have just enough sauce to hold things in place where it's required, but not too much so it's dripping everywhere. Everything's been layered just right, so the sandwich is stable, supported, comfy, and functionally ready to enjoy life. So if I bring that back to person's body, we're basically determining what that person's body can do, can't do, and find positioning that supports that person's comfort, ability to function, and anatomical symmetry where possible. And then we trial equipment and we try to replicate that posture or that sandwich design. So we want to look at doing this as part of a process with looking into any type of seating for our clients. I mentioned before it would probably relate mostly to wheelchair seating, but if they have complex postures, you might be considering it for an alternative custom seating in some sort of recliner or for overnight sleep positioning. But, big but, is rarely do we see a sandwich like this one in the picture, where everything is beautifully level and symmetrical. I guess maybe in advertisements you do, but not in real life. And the same goes for postures. So don't be concerned on focusing about that perfect posture and what a perfect posture should be and getting too caught up in numbers and measurements. When we've gone through uni, I think there's quite a traditional emphasis on achieving that 90-90-90, flexion at the hips, knees, the ankles, but how functional and comfortable is this position actually? How many of us right now on this meeting are actually sitting like that? I doubt many of us. So it's often pretty uncomfortable and difficult to maintain. So when we approach our assessment for our clients, we should be considering postures that are as symmetrical as possible, but not needing to be perfectly symmetrical in every way. Let's go through some of the influences of our posture just briefly. And again, to keep it kind of light, I'll try and equate it to some sandwich ingredients for you. Number 1, person's body size and shape. So like the bread shape of a sandwich. It can really vary, and that might impact how the load of the sandwich fillings are distributed. So how their body weight's distributed. The second one is person's range of motion. So how much can each ingredient move? Number 3, a person's muscle tone or spasticity. So similar to the example previously, can we move around a lot because of low muscle tone? Or is everything really tight due to higher muscle tone? So there's many more, but I'll focus on these few. Lastly, number 4 is bringing it back to the activity that person is doing. So does the sandwich need to stay stacked in that same position for a while before it's eaten? What way does the sandwich need to be orientated to have the best functional reach? A stable base of support, supporting physiological functions, and reducing pressure across the body. So basically bring it back to the client and what they need to be doing in that posture, really knowing the task or their occupation, which is something OTs are great at doing. As we complete our postural assessment or mat evaluation, we will be identifying certain postures that may be unique to our client. And then we want to find out if this posture moves or if it's stuck. So first off, a fixed posture where it's stuck means it won't move. Or if you try to move it, it makes the rest of the surrounding limbs or body shift with it. So then the aim of our equipment is to accommodate to this and try to keep it where it is at so it doesn't get worse. We're not going to be able to fix it. So second option is it's a flexible posture, meaning it moves a bit and it'll be independently moving from the limbs or other body sections around it. So it's not causing those resulting shifts. And the aim of our equipment then is to help correct this to achieve a more symmetrical posture that promotes comfort and function. So like I said before, it's unlikely to be a perfect 90-90-90 position. But for larger postural deformities that are flexible, we do have to do this correction process very gradually. So for those really complex postures too, I'd always be linking in with someone else and collaborating about how you would go about that correction process. If you do everything too quickly and too harshly, you pose a risk of other issues or pressure injuries because you're just trying to push too much when it's not ready. With our optimal posture, we're aiming to keep our life box. I want you to think about this term a lot, life box. So that area between our ribs and our pelvis, tried to show it here on the photo on the left. We're trying to keep our life box nice and open. So keeping If you want to think about it with the sandwich, the bread piece is nice and level and open. And this is really important for some basic functions. I like to call them the 3 Bs. So breathing, bladder and bowel emptying, and being able to swallow and cough or expel what we need to safely. As if you even try and recreate that posture now, so if you scrunch in your life box, lean forward, you're slouched, it makes all those things a lot harder. Trying to swallow, cough, breathe, it's all a bit scrunched up. So really keep that in mind in terms of then health implications for your client, but also functional task implications. I doubt that's going to be a very useful posture for them. It's probably going to be quite uncomfortable if they're sustaining that during a task. So we've gone over fixed, flexible, why we do it, the life box. So there are all some general terms just to be easing you into this, but we'll get started on some ways we can actually go through the postural assessment. As you prepare for the postural assessment, do consider the client's situation, including their medical history, their disability, including if increased tone or spasms will be exacerbated when you lie them down or in a changed position, because that'll make doing this postural assessment quite tricky. Their sensation and whether they have any active pressure injuries, because that can definitely be a contraindication to placing them in these positions. Their respiratory needs. So if they're at risk of aspiration, really considering then, well, yes, what can we do to support them? How they communicate. Do they understand basic task instructions? So being able to relax, not move, allow us to do our assessment. Are they going to understand that? But think about how you can be creative. Get their support workers who are familiar, who really are able to reassure them. Do what you can to make it as pleasant process as possible. And following on from that, behaviours of concern. So this is a particularly important one because it has been a direct barrier for me being able to complete MAT evaluations in the past. Based on all of this, you might find that then you can't do a MAT evaluation, or you can't do a full MAT evaluation. And this is all too common, but it doesn't always mean we have to abandon everything. We're good at adapting across the allied health profession. So think back to my first point around move and test, so the crux of a MAT evaluation. Try and think of these principles and whether we could still do some kind of visual assessment, ask them to reach forward, for an object and see how that impacts their trunk and their posture, or try and move their body a bit while they're seated in their familiar chair, just to understand a bit more around how their body's moving and what's promoting their function and their comfort. It's going to be better than not doing anything at all at the end of the day. So if we've gone through those pre-assessment considerations, we're thinking that, yes, we can move on to the MAT evaluation, it's okay. Then there's 3 basic considerations. So first one, have a quiet, private space. I know in reality, we will probably not be in a clinic with a beautiful plinth. So that doesn't mean you can't do a MAT evaluation. Find what stable, solid surfaces you have around you. So a firm, flat surface such as a foam mattress is okay. It won't be ideal, but it's still fine. Or even transferring onto the floor. If you evaluate risk and deem that that is appropriate, it is something I have definitely done before. It's a good way to see their floor transfers as well, but it's totally fine. Second consideration, try and have the client wear some thinner material clothing or something that's more fitted. It will make it much easier for you when you're palpating the bony prominences. Last consideration is have 2 people minimum. So either professionals, this is where OT combination with physio is awesome. I've done it many times with a physio. Physios are very used to moving the body, looking at range of motion, palpating. So I really would suggest have 2 people. It's going to be way too much manual handling for you as one person. Ideally then, for the MAT evaluation, we're going to conduct the hands-on assessment with the client in 3 different positions. Position 1, we first observe their posture in their current seating, such as their wheelchair. Doesn't have to be, but would usually be their wheelchair. Then transfer to the lying or the supine position. Then we have them sitting on the edge of the bed or the plinth, or just a level, stable seating surface. So in the home, I've done before is grab a dining chair that doesn't have armrests. It's usually they're a pretty flat seat. If the chair does have armrests, then just ask the client not to use them or lean on them if that's within their capacity. So for each of those 3 positions, current seating system, lying, and then sitting, we are going to be looking at the position of each of their body part or segments. I always start with the pelvis because I like to think of this as the person's base of their posture. A lot of things that link from it. Then move to everything else that extends out. So we can work up or down the body. It doesn't have to be a certain way you do that. I tend to work down first, but see what works for you. So looking then at the person's thigh position, their lower legs, their feet, and look at up, when moving up, their trunk and their spine, their head and their neck, and their upper limbs. Throughout all of this, we're looking at how these body parts are positioned across 3 views. I'm going to use less technical language here, but the technical terms are at the top. So the front, the side, and the top. Frontal, sagittal, transverse. They're the different planes that we're looking at. I also can't stress this enough. For those of you that have done a mat evaluation with me already, you've probably seen I'm taking heaps of photos. So for each position, when they're in their current seating system, when they're sitting on the edge of the bed or the plinth, and in supine, take photos of each of these positions and do it from those planes. So the front, the side, and the top. Okay. A picture paints 1,000 words. So you can go back and review the photos later if you wanted to have a look at something or you can't quite remember. Plus, suppliers love receiving these photos. So when you're sending through a seating referral, like for complex seating, often suppliers or specialists who are OTs in the equipment company will be aware of mat evaluations and will be looking for some of that information from you if you're going for something like a seating matters chair or something really complex. So send them the photos. That really helps them too. When we're feeling for certain postures, we do have to locate a consistent spot to help us understand how each of those body segments that I was showing you, like the pelvis, the thighs, etc., how they're moving and how they're positioned. So I'll go through some of those as a brief kind of anatomy review now. For the pelvis, the main body landmarks we need to know are the anterior superior iliac spine. So just got that one here. And then the posterior superior iliac spine. So you can see they're kind of like the notches on the front and the back of the pelvis. You've got this large iliac crest or the curved edge of our pelvis, and generally that's the easiest way to think about where the AS and PSIS are, because you can feel for that iliac crest, and then at the very front part where it drops off, that's the ASIS, and right at the back where it kind of goes in is our PSIS. From the side view, sagittal plane, we are looking at pelvic tilt. If our ASIS, so that's the one on the front, is higher at the front, and then the PSIS that's at the back. So you can see I've shown that in the picture. You can see that kind of line drawn between the two. That's quite an exaggerated one, but that is posterior pelvic tilt. Conversely, if the PSIS at the back is higher than the ASIS at the front, drawn the line here, then it's an anterior tilt. So for some of our clients, it can be hard to find that ASIS and PSIS, particularly some body shapes and sizes. So again, don't abandon the mat just because of that, but have a think about trying to find a certain spot. So even if it does mean just feeling more for this iliac crest and trying to see, is it generally tipping forward or tipping backward? Because that will still give you some idea about tilt. But just keep it simple. From the frontal plane, we are looking at pelvic obliquity. So you can use either the anterior landmark or the posterior landmark, so ASIS or PSIS. For this example, we're using PSIS, so from the back. And then you're going to look at which one's higher or lower, or if they're level. They might be level, and that's fine. But if our right PSIS is lower than the left PSIS, then it's a right lower or left higher obliquity. If our left PSIS is lower than the right PSIS, then it's a left lower or right higher obliquity. Generally, I use the side lower term, but again, as long as you make that clear, which one is higher and which one's lower, it's fine. Lastly, from the top view, so remember I said we're doing those 3 planes, side view, front view, top view, starting with the pelvis. So top view, we're looking at rotation. So again, you can use ASIS or PSIS as the landmark, but for this example on the diagram, you can see we've used ASIS. So the front one, if our left ASIS is rotated further forward than our right ASIS, it's a left forward rotation. If our ASIS on the right side is rotated further forward than our left ASIS, it's a right forward rotation. Okay, so that was the pelvis, the main terms we need to be familiar with. Let's move on to the trunk. There's a few postures that, again, and terminology that is good to be aware of when we're looking at how the trunk and the spine is positioned. So the first is scoliosis. So that's like the sideways curvature of the spine, often forms like an S or a C shape when you view it from behind. So some easier visual cues that there may be scoliosis. If you're not able to kind of feel their spine as well for various reasons, look if they have uneven shoulders or hips. That's one clue that maybe there's something going on with their spine and trunk posture. Maybe ask the client to bend forward, and then you can look, there might be a visible curve or like a rib hump along the spine. That tends to also suggest there might be a bit of scoliosis. Then next, we also look for kyphosis. This can be more common amongst a lot of the patients that we see. So it's that excessive outward curvature of the upper back, resulting in a rounded or a hunched posture. It's easiest to see from our side sagittal view. And these people will tend to be those wheelchair sitters that look down, they're more closed in. So probably the ones you've seen quite commonly. But last, we can consider if they have lordosis. So that is an exaggerated inward curvature of the lower back, so the lumbar spine. Again, easiest to observe in the side, sagittal plane. So often it will mean that their buttocks protrude out a bit more than usual. You can see that in the diagram there. And these people will tend to be the wheelchair sitters that are more opened out, maybe have their chest pushed forward, their head kind of tilted back as they're trying to balance out, I guess, their center of gravity when they've got such a lordosis happening. Then for lower limbs, as the next body segment, let's look at some basic terms to make sure you're familiar with them. So wind sweeping, got that in the picture here. So this is when one leg is positioned in like abduction and external rotation, while the other leg is in adduction and internal rotation. So it gives the appearance that both legs are swept to the side. One thing that's important to understand is that this posture can have some associated rotation of the pelvis, but that the posture is most likely coming from the lower limbs, because we don't want to get confused between, well, which body part is actually the one causing this posture. Because if you try, like this person here, if you simulate right now a bit of a right forward pelvic rotation, so bringing that right side of your pelvis more forward, it looks a little bit like this posture, but notice that your thighs are actually not rotating so much. They're actually still in line and remaining reasonably symmetrical. But then if we go back to our normal position with our pelvis not rotated at all and just shift our legs, you can see how that creates a lot more rotation in your legs if you're trying it out right now. So again, that's where it's really important to understand where the posture is coming from, because then that is different interventions that we would use based on where it originates. This type of posture is quite common in our cerebral palsy or neuromuscular condition population. And generally it creates, if you did just try it just then, you could see it creates more of an unstable sitting position, and it can worsen pelvic alignment over time. So even if it does start with your lower limbs, it's going to probably start to contribute more to pelvic positioning issues too. So it's really important. We want to see if this posture is a bit flexible, try and correct it where possible. And we've got some great cushion options to be looking at that with deep contouring and troughs. Remember to familiarize yourself with those terms that you've probably done more at uni: abduction, adduction, external and internal rotation as well, just to make sure you're on the same, speaking the same language when you're doing these types of assessments. Because the physios will be really familiar with it. Most of us OTs will be too, but just make sure you're really familiarizing yourself with those. We'll move on to another body segment, the feet. So again, E version, where the foot rotates outward. You can see it here in this picture. Inversion, where the foot rotates inward. So that would be easiest to see from the front, the frontal plane. And then move to the side for these next two, dorsiflexion and plantarflexion. So you'll see dorsiflexion is more where the foot is pointed upward. So that's this posture. And plantarflexion is where the foot is pointed more downward. I've also seen presentations of equinus deformity, which is a limited upward bending or limited dorsiflexion of the ankle joints, causing the foot to be more stuck in this kind of pointed down plantar-flexed posture. You might have seen that a bit with some children who have cerebral palsy, or those who haven't had much mobilization, so prolonged immobilization, so sitting in their chair for a long time, they might develop that sort of posture more. And again, we look at whether it's fixed or flexible. So if it's flexible, great, but if it's fixed too, how can we accommodate for that in our foot plate positioning? Next body segment, the shoulders. We can look at how the shoulders are positioned. So are they elevated? So that kind of upward position. Are they depressed? So that's this diagram here. Also with depression of the scapula and the shoulders, do consider how the armrest position on the wheelchair might be affecting this. So when you're doing that first position in their current seating, if you've got armrests that are super high and you're asking them to put their arms on the armrests, that could be either causing elevation, or if it's too low down, it's actually causing some depression in their shoulders, but it's not actually the person's posture. It's because of the seating that they're in. And we can also look at if there's any adduction, so retraction of the shoulders, or abduction, protraction. So that's like the rounding forward of their shoulders, which is probably more common posture we'd see. When we're doing all of our planes, this is mostly from kind of the frontal plane. You could look from the side as well. But then in terms of the top, look also from the top, because that's our third plane, to see if there's any rotation. So if one shoulder's more forward rotated than the other, that probably will relate back to their trunk body segment as well. So with the spinal position, but just generally have a look at that. So we follow that process for looking at how each body segment is positioned in those three in each of the three positions, but it might just be that you're only able to do it in sitting, but I would suggest a lying in a supine position is really helpful because that's the gravity eliminated position. And you've been able to take away some of the basic principles around postural assessment. But as I said at the start, it's definitely a journey and something you gain confidence with through practice and implementation.